Hello, everybody, and thank you for joining us. We're going to get started here. Um, I want to just share some kind of some housekeeping slides. Just a reminder that all of you are muted, and we will do question and answers in the question and answer box. So a little information about Kidney Foundation. We service 32 counties in Ohio, providing direct assistance for transplant and dialysis patients. And we remain one of the only organizations to provide direct assistance for kidney patients. Today's webinar will last an hour. You must attend the entire presentation to receive credit. Questions and answers can be submitted, as I said, in the question and answer section on the bottom of your screen. And for information about future sessions and other information, you can visit our website at kfohio.org. So just some disclosures, no one with the ability to control the content has relevant financial information within an eligible company, except for Amy Hazel, who is a speaker on the Speakers Bureau for Fresenius Renal Pharmaceuticals and Akebia, and our presenter, Joe Rogucki, who is an employee with Adapt Health. These relationships have been mitigated. Again, you must attend the entire session, complete an evaluation by next Friday. Your certificates will be emailed to you by next Friday. And finally, we have been approved for continuing education hours for nurses, social workers, and dietitians. Just some upcoming events that I want to let you guys know about. Maybe. In December, we will be doing a webinar based on how to ask for a living donor, which will be in collaboration with University Hospital. So if you're interested, please, after the presentation, we will send out the links with that information on how to register. Friday, December 5th at the Music Box Supper Club, the KFO will be celebrating their 75th anniversary with the Diamond Project concert at the Music Box. This is a Neil Diamond cover band. And finally, in January, we will be having a urinary tract infection in kidney patients webinar. So keep looking out in your emails for information about those. So at this time, I would like to introduce Joe Rogucki. He is an LPN, works with Solera Health, which is an Adapt Health company, and he's going to talk with us about continuous glucose monitors and just some information and how it relates to patients that we're working with. So I'll turn it over to you, Joe.
Oh boy, thank you. What a great introduction. I appreciate you, Jen. Good morning, everyone. Welcome on board, and thank you for taking time out of your lives to learn a little bit about CGMs. I happen to be, I guess, an LPN, a nurse. I've been working in the field for, 40 years plus. I'm an Army nurse. Once upon a time, I did work some med surg in that, and I've also been through working with sales, and for the past 25 years, oh gosh, 30 years, oh, it's been too long. Anyhow, this last 5 years, I've been working with Adapt Health or Solera Medical, and specifically selling CGMs and insulin pumps. So kind of my wheelhouse, just learning about these products and just getting them out there to the doctors and the offices and patients. Let's see, that goes with my welcome that I wrote down. So let's see, before we begin, a quick disclosure. It's for educational purposes only, and it reflects current guidelines and published data on continuous glucose monitoring. I will say continuous glucose monitoring only once. It's CGM for me. I have no financial interest in the other than my employment with Adapt Health. And on Focus today, we're going to look how CGMs have evolved, their impact on patient outcomes, and how we as healthcare professionals can better navigate access and coverage for our patients. Let's see. Yeah, there it is, the learning objectives. Thank you. You already went past that title slide, so that's good. So by the end of this session, we are going to explain the history of CGMs, current usage for patients with diabetes. We'll recognize the different CGM brands, identify similarities and differences. We'll understand the impact of CGMs on patient outcomes, and we'll identify insurance coverage issues related to CGMs. So there we go. Next. Jen, did you freeze? Hello. There we go. Fantastic. Oh, so let's talk about the history, the evolution. It begins in the 19th century. The earliest glucose testing, it relied on urine analysis, which only gave an indirect and delayed measure of blood glucose. These tests, they lacked precision and they provided no real-time insight. And as clinicians, we know we can appreciate how limited that was. Results may reflect what glucose was several hours ago and not what is now. Um, Being an old Army nurse, we did use urine testing as well as the next step, which is the blood glucose finger sticks. So, next slide will bring us from the 60s to the 90s. All right. So blood glucose meters started coming out in the 60s and the 70s. The early ones, yeah, they were okay. They weren't as accurate. Again, it relied on finger sticks. And, when you have those patients that are 4 and 5, 6 times a day, they really were a pain. For the first time, patients could measure their blood sugar at home, self monitoring of blood glucose. It became the gold standard. I mean, this has helped keep a lot of patients alive for many, many years. While this is transformative, it still only offered a single data point. Clinicians were missing the trend information, which means it had a less ability to anticipate or prevent a hypo or a hyperglycemia. Um, it was explained to us is a blood glucose meter is like it's riding the caboose of a train, and your blood sugar is going up a hill with the train and the engine's over here. That's really where the blood glucose is reading, and you're in the caboose and it's going up over the hill. And so you may be reading a 160, and oh, that's kind of high, but you didn't realize it was going to go up to 220 and then come back down here where the engine is. So it just tells a picture of time. So we're going to fast forward to the next 1999. We're all wearing, well, it's past the 80s with the big hair stage. So, all right. So the first CGMs were developed. Let's see. 1999, the first FDA approved continuous glucose monitor, CGM. It was a mini med. That's a product that's still out there. It came to market. Since then, the innovation has accelerated. There's companies like Dexcom, Abbott with Freestyle Libre, Medtronic, and you're also going to hear about Eversense. These products are out there. We'll discuss those at length a little bit later. They've all refined accuracy. So how these do it, it's amazing with all the new technology, the new little tiny chips, and they're making it so that it's almost like Star Trek when they're scanning you, and we're going to tell everything's wrong with the patient. So today's CGMs can provide near real-time data and predictive alerts, seamless integration, and with insulin pumps and smart devices, your phones. So that's really, it's a game changer. It prevents patients from having to keep extra equipment in their pockets while they're out and about. They're able to use their phones, and what's really cool about the advent of this, it also has the ability. Most of the we'll talk about the other companies, Dexcom and Abbott. They're able to send that information over to the physicians, and so the physicians can see in real time, hey, my patient's glucose for the past 6 months has been within range, or hey, you've been really dipping at night for some reason. Let's check that out. All right. And let's slide 7 is basically the same thing. We're going to bring it up. um, I think that's just talking about more of the same. So let's go to the next slide. I think we're going to. So you think about CGM, what it does exactly. So it, it measures the interstitial glucose every 1 to 5 minutes, and it reports it to your cell phone or a reader device. It transmits that data to your smartphone, and it alerts for hypo or hyperglycemia in a daily monitor tracking. And so, what's real cool with the information that's on these, you can track everything from what's in the last 3 months, how the levels have been going. I happen to be a Libre user, and I'm going to go. I'm going to share. Let's see if I can share my reading today. There we go. Oh, can you see? It's 111. If you can't, it's too bright for the camera. My apologies. That didn't work out well. So I'm really decent right now, but I can also look at my insights and look at when I can look at reports for my highs, my lows, any low events, any high events, and it can tell me basically after I eat supper in the evening, my blood glucose goes up. It's around 200. So, being a type 2, it's okay. I'm within range at 98% of the time. So, this sends the information to my doctor, and she reviews it when we do our visits, and she says, hey, at nighttime I notice you're getting lows. Yeah, that's a thing. And I guess now's a good time to talk about nighttime hypos. And for a lot of you, your patient is really concerned because at nighttime when that alarm goes off, it's scary. It's like, well, am I having an event? Will I need to go to orange juice and sugar? Let's figure this out. It's a simple thing. A lot of times your sensor, you're laying on it in the bed. And what it's doing, it's compressing that tissue in that area, and it's pushing the blood away from that area. And thus you start reading a low that's not really a true low, it's a pressure low. And those will report as hypos in your smartphone or your reader. So one of the things I do to mitigate that, it's a simple thing, as I put a pillow next to my arm, that the side that I have the sensor on, and then when I'm laying, my elbow hits it, and the sensor is kind of free from being pressed on the sheets. So insider information for all of you, and hopefully that helps in the future. You'll have that tidbit in your head there. All right, let's go to the next slide. Ooh, the Dexcom. All right. So Dexcom's a real time. Happens to be a G6. If you see that little oval shape that it is, Dexcom also has a G7, which is a round sensor. It looks closer to maybe the Freestyle Libre, but it's just a hair thicker. Um, G6, it requires that little gray. If you see in the picture, the little gray thing in the middle, that's actually a transceiver that sends the information to your smartphone or your reader that the patient saves for 3 months. That gets you have to take that out of a holder. There's a little plastic holder there that's holding that in, and you get to reuse that. The downside of that is patients will throw that away by accident. It happens. Yeah. And as a company, we've been able to replace those on occasion. So the G7 has kind of replaced that. It doesn't use a transponder, should I say, and it uses it. It's built in, so we don't have that issue anymore. The G6 and the G7 currently are 10 days of use. And if you're thinking of a patient that's using this, they'll have to change it every 10 days. They'll get three sets per month. And that's kind of neat, except they've also developed a 15-day, which is coming out in December, possibly January, out on the market. So that's on the way. Um, it's a G7. It's round. It won't need the transponder. It has it in there, and it will last 15 days. It comes with an overpatch that you would put it on. And I thought there were words on this, Jen. I thought, there we go. So there it is. 10-day wear, calibrated factory. We don't have to do finger sticks to, calibrate it. Real time. It has alarms and it integrates with insulin pumps. So that's what makes the G7 kind of desirable for type ones. They're going to be able to, connect with those pumps and such. So let's go to Libre. All right. So the old Libres were 14-day, and those are starting actually to phase out. The Abbott's going to be discontinuing actually servicing those at the end of this year. So if you have patients on the old 14-day, and the 14-day, one of the things you had to do was take your phone or your reader, and you literally had to beep, scan your arm to get the reading. That's a step up from finger sticks, but it relied on the patient to actually physically do something. They should be switching over by now to either the Libre 2 or the Libre 3, and they call them the 2 Plus and the 3 Plus now. That's the new products that are out. And those are 15-day wear sensors. So they've upped the game. It's compact. It has a minimal lag. It's cost effective. Is as far as cost for the patients, we'll talk about that later with the insurances. But the Libre is a little less expensive, and it has to me, for me, it worked for me because I had an allergy to the Dexcom adhesive. So it happens. It's not normal, but my skin isn't normal. So the Libre 3 apparently does not, and it works fine. Sticks on for 15 days. Both the Libre and the Dexcom will replace a sensor, and now they'll replace it through the manufacturer. So you got to call Abbott or you have to call Dexcom directly, and they have a program for this. If a sensor falls off, if a sensor malfunctions, anything happening where it's not giving an accurate reading for some reason, the manufacturer, they ask the questions, they do everything, and then they ship it out pretty much really quick. So my last one fell off. I was working in my boat and it caught on the entrance of the boat as I went through, and it just yanked off. It happens. And so called Libre. They basically asked me all the questions. Sometimes they want the sensor back, sometimes they don't. So they asked for the sensor back. They sent a package. They had it all ready, and it was ready to mail back to them. So a lot of times the patients will call us to say, "Hey, I'm out of sensors." But we look at their records and they should have had plenty. So we ask the patient, "Hey, did you have a sensor fall off, or did something happen with one of your sensors?" That's a good, important question. And they'll say, "Well, yeah, it fell off. I got it caught in the tree or whatever." And they'll expect us to replace it. That's when we send them to the manufacturer, and the manufacturers are really good about that. So that's next, and we're going to do our next slide. The Guardian sensors. You may not see these a lot if you're working with type 2 diabetics, but The Medtronic is a very integrated system with the Medtronic pumps. And it does have predictive alerts. It requires calibration. They call it robust because it's a closed loop system. In other words, it works in conjunction with the pump and delivers the proper amount of insulin for what the blood sugar is doing. So it's a really cool system. It's a game changer for type 1 diabetics who basically, need that. Um, I don't think I have anything else on that. One of the things with the Guardian is it usually does not work. It won't work with a tandem pump or another brand of pump, whereas the Dexcoms and the Freestyle Libre, because now Libre 2 Plus will work with tandem pumps. It'll work with the Omnipods, if you've heard of those. Those are the insulin pumps that are we call them cordless. They don't have the tubing in that. It's a direct onto the skin. So Medtronic Guardian is again, it's a direct and it works. And years ago, we're not allowed to say it, but I'll say it. It's the pardon me. It is the artificial pancreas of the system. So it's supposedly they don't claim that, but it is a very effective pump CGM combination. And the next step from there. So if you haven't heard of these are around. These are the Eversense implantable. Got to go back. There you go. Eversense implantable CGMs. Now, so those go usually under the arm, back here, under the skin, and they're implanted, and they can go up for 6 months of use. Now, the sensor that the hand is holding there, that little sensor there, it doesn't stick on it. It basically sits on top of that, and there's a strap that goes around the arm. So when they want to take it off to go swimming or do whatever activity, they can, but then they put it back on, and once again, it's readable. The downside of this is the professional placement in office. The doctors need to be trained. It is a surgical procedure, and it's a slight incision and such. There are a lot of doctors, especially endocrinologists, and that who just they're busy. They don't want that into their life. There's a lot of internal medicines that will use these, as opposed to the endos, but there's a few out there that do use them. So it just gives another chance for somebody to have a CGM without the daily, checking on it, what's going on. They can put that sensor on top. It still requires that sensor. So, yeah, it's a great option. So it's just something different that's going on. I know overseas they're doing studies with this Eversense for a yearly implant. So that's something that might be in the future for America. We'll see. But again, they're all great options for our patients. So let's see. Clinical impact. Uh-huh. Evidence based. All right. So, personal witness to this, I went from a A1C of 13.9 a year and a half ago. Nope, 2 years ago. To currently, I am at 6.9. So I've reduced reduced my A1C by an awful lot. I'm getting close to being within range. But we can see that Norman did a study back in 2024. You'll have the things for this down bottom. But a 224 real world evidence study by Norman and colleagues showed that initiating CGM was associated with a zero point 0.4 reduction in A1C and a 6% increase in time in range. And the biggest thing for this is lower hospitalization rates. Okay. And these findings confirm that many of us see in practice. Continuous data supports tighter control, fewer hypoglycemic episodes, and improved overall health. And so Definitely, even our type 2s can really benefit from a CGM. You know, they're going to learn they can't pound down a bag of potato chips. All you dietitians are squirming right now. You can't pound down a bag of potato chips and expect your blood sugar to stay within normal. Or, my bread intake is so much lower per day. Just looking at what my blood glucose is doing. Hey, I can eat eggs and toast for breakfast and have a sandwich for lunch. And then maybe later on, we'll have some other kind of carbohydrate with, well, let's have pasta in the evening. And then you find out how that really affects your blood sugar, your blood glucose once you have it, looking at you every day. Here's, oh, I've got an alarm. Oh, it's high, So that is very important with the CGM. It gives a real time, real world effect of what your diet is doing for your blood glucose. So I think to me the quality of life is so much greater when you have the knowledge of what you can do with your blood glucose and what's going on with your sugar. All right, I'm blabbing. Let's go next. All right, just like Hogwarts, the doctors and the prescribers will fall into any one of these four houses of CGMs. So you're going to go to a doctor, they're going to be a Libre doctor. You're going to get orders from a doctor, they're Medtronic. It's again, it's what they're comfortable with. It's what they believe is the best for their patients. But they definitely are going to go to a different house. And I'm just going to say it's just like Hogwarts. So Gryffindor for 10 points. So there you go. All right, let's go beyond that. Beyond the quality of life, and these are the technical facts. We do have the less fear of hypoglycemia, and if you're for me, hypoglycemia, it's real. When I exercise a lot, it really plays into my life. Once I get into those lows, that nervous, shaky feeling that is horrible. And I'll pound down way too many carbs to get it back up, and then you're on the reverse train, and you're just feeling very crappy as your blood sugar reaches that peak, and you know it takes several hours to feel normal. And so having the ability to watch those numbers before it happens, it's just a blessing. It really is. So greater confidence in meal and activity planning, reduce testing, glucose. Hey, when I hit those lows, believe it or not, even with Libre, I will do a finger stick, and I'll see. Are we really that low? Or are we, what are we trend? What are we going that way? So I'll do that finger stick just to double check what the data is. Reduce testing burden. Real time data empowers self management, as I've seen and as you've seen. There is a greater compliance with our patients, and this is it is a life changer, should we say? So let's talk about coverage. It's whoops. Hey, you went all the way to the bottom. Keep going. I think it's one more up. There we go.
So, Joe, I
So in the
have a
last couple,
real quick
go ahead.
question. In regards to, as you're talking about the like you'll check with a meter, if to kind of compare. Can you talk a little bit about like the what it means by the interstitial measurement, and how like the finger stick would compare to the like the CGM?
Oh, absolutely. So we're looking at the nurses are going to cringe when I go, oh, this is the explanation. It's not that. So what we're looking at is when you're doing a glucose finger stick, again, it's that train analogy. We're looking at what's happening at the end life of that blood glucose in our system. Whereas the CGM is reading a deeper interstitial tissue. It's getting more of a direct blood flow, or should we say a direct reading of what's happening in that interstitial tissue, as opposed to what's in that fingertip glucose. And so it's more accurate in the means. I know they all have their numbers, as far as the CGMs, which ones, oh, we're within those mean levels of glucose readings and such. And yeah, that's important. But again, the to me, it's the comfort, the convenience, and the quality of life outweighs all those stats. And so that's to me, that's what it is. I hope that helped. All right. Coverage landscapes. Ugh. So, Medicare and Medicaid. Okay. So, a few years back, before COVID, a couple of things were happening. When you had coverage for CGM, it required insulin. It required a diagnosis of type 1 or type 2 diabetes with insulin. And it also required you to have 4 finger sticks per day. So again, it was a fight and a really struggle to find patients that, so usually your type 1 diabetes on 4 finger sticks per day and insulin, and with a type 1 or 2 diagnosis, that's what the coverage was. So as we move fast forward through COVID, it became really apparent that patients were not receiving the care that they needed with insulin, I mean, with the CGMs and readings. So Medicare actually slackened the requirements for that. Right now, we are currently, on, honestly, it's one it's no finger sticks, and it's on 1 injection per day of insulin. Now, they've also loosened that even a little more. It's a little harder to prove, but with documentation, we've been able to have some CGMs go through with, they call it 2 critical events of hypoglycemia. Now, that can be a documented report in the doctor's notes. Hey, the patient felt dizzy. The wife gave him orange juice with sugar. This happened 2 times in the last week. Okay, so Medicare really decides the number for that issue. So they're going to say a hypo below 54. When the doctors document, one of the problems come in is they'll document lows below a 54. Medicare will kick it out because it's not 53. So in our government's knowledge, it's great. They give us a number, we match that number, and then they say, no, it needs to be lower than 54. So for all those nurses out there, and all those providers, you got to understand it's going to be 53 and below for hypos, or if they had a hypo event that required emergency room hospitalization, we have notes for those, and also a critical event that the patient was treated at home but reported it to the doctor. So again, gray area, it happens. It's ability to get that approved through Medicare. So let's recap. It's 1 insulin injection per day. So, or 2 hypos documented. And that's how they report it. I'm going to, if you need that paper, I do have a Medicare guideline from my company, and basically it's the same for every company. So if you want that, at the end of this, we can figure out how to get that to you. Um, Private insurances are increasing eligibility, and this is the big thing because most private insurers now are trying to push towards CGMs at pharmacy. That's great. They can just pick it up at the pharmacy and keep rolling as long as they're compliant. That's a good thing. Um, Companies like mine are called durable medical equipment companies. Now, Medicare, let me backtrack a little. Medicare requires a medical equipment company to provide the CGM. It's part of their guidelines on our requirements, what we have to do. A new Medicare patient is required, even though they may use their phone, they're required to get a reader. They need to have the entire equipment to make it legal for them to use it. So I think the the thinking behind that is that if their phone were to be unable to be used, they have the reader that can. And so, with that being said, Medicare put that rule out. And so, whenever we have a new Medicare order or even an upgrade, we still need to provide that information that they have the reader, they have the ability to do that testing. So, private insurance. Let's skip forward to that. Okay, most private insurers are covering a type 2 and a type 1 diabetes. Some of them require the insulin. Some of them are just doing a type 2 and just going, hey, you're a diabetic, you can get the CGM. It depends on the insurance. It's a minefield out there. It's very difficult to figure out, well, this insurance does this and this insurance does that. Um, to me, I'd love to have a standardization of all DME versus, pharmacy. But until the higher ups make that happen, this is the landscape we deal with. The downside of private insurance is people drop coverage and they switch to, they go from Aetna to Anthem, and again, now their coverage changes. There are a few private insurances out there that will cover a Dexcom, but they won't cover a Libre or vice versa. So it's finding out what somebody's insurance will cover. A lot of times the patients are reluctant to call their insurance. Oh, I don't get the information. Can you do that? So that puts the onus on us as the care providers to find out what's going on with these, the patients and their insurance. And, waiting online and hearing cues is always the fun thing to do. So we'll put that under the persistent barriers. Some insurances are still requiring authorizations. Um, Again, that talks about the formulary restrictions, the Dexcom versus a Libre versus a Guardian. And then we touch base on pharmacy versus medical. Oh, why is my battery running low? No, I did plug in my device. Hold on a second. I'm sorry, y'all.
Joe, while you're
I found it.
attending to that, I did have a question come in. So,
Please, please.
um, someone is asking, can you comment on just the application of the CGM that a patient needs to do? So how they put the device on, and do you find them having to change it out every 10 to 15 days being a barrier to adherence? And after the 14 days, for example, with the Libre, does it just stop working?
All right. Yeah. I Let's start from the top. Applications are manufacturer says different ways to do the applications. Dexcom, um, they all have an applicator that will put it on, and Dexcom itself will say they have an over patch that needs to go on. Personally, what I use is Skin Tack. I actually shave that area. It gets all the hairs out of there, and it tends to stick a little better for me. So I do shave that area. I'll use Skin Tack, let it dry. I'll apply the sensor, and here's my wild trick. I use baby powder. I'll put a little baby powder on my fingers, and I'll tap it. And what it does is it prevents it from sticking to my shirt. So that gives me my whole 15 days. Very rarely have a fall off. Even, summertime, again, we're all sweaty. You're working, you're doing stuff. Most of my fall offs are related to hitting something. I swim with mine, it works great. The Dexcom will do the same. Dexcom, the G6, it actually goes on the abdomen most of the time. That's the recommended placement. Although you will see it on the back of the arms, you'll see it on a leg. You'll see it, on just different locations, just because the patient's preference on some of that. Libres are behind the arm with that. Oh gosh. Okay.
And
What was the rest
then,
of the question? I'm
yeah.
sorry. Thanks.
Do you find that like patients when they have to change them depending on the product every 10 to 15 days that it becomes a barrier or with adherence, or are they pretty compliant with that?
Believe it or not, they're pretty compliant with that. That is seems to be, the alternative is the finger sticks. And yes, we still have patients that's what they prefer. But to me, what I've seen is when once a patient finds out, hey, I can do this 14, 15 days, they're sold. It is really it's a game changer for compliance. uh, we in the DME industry like to think that we help the compliance because we're always in contact with the patient about their reorders and availability. Um, to me, I don't want to sell, pharmacies short or not, but sometimes patients don't go to the pharmacy to get their supplies, or they find that a barrier that it's easier to get it just shipped to their front door, and they use the product. So I would say I do not feel it's a barrier.
Okay. And then what about like the sensors at the end of their life cycle, I guess to say, so with the Libra, like after that 14 or 15 day, does it stop working?
It does actually. It will tell you. You get warnings. Like I just had a warning this morning. I have 3 days left on my sensor, and so it will tell you you've got 2 days left. You've got 2 hours left. You've got so your sensor will end in 15 minutes. It tells you that. So if a sensor ends, it's fine. For me, I have my alarm set. It doesn't go off. It just, I know it's ending, and I don't need an alarm to tell me that my sensor's ending, but it will beep. If your sensor's done, it goes beep, beep, and you look at it and you go, oh, your sensor has ended. So at that point, you just pull it off. You get prepared to do a new sensor right away. You know, for me, I've long term use. I've been on a CGM for 3.5, 4 years, and I'll just put it on in the next morning after I shower. So it's just kind of for me, it's convenience, and I know what my blood sugar. If I feel level, I'm doing good.
And then I've got another question that just came in. It's this person says, I'm a type 1 and my endocrinologist does not want me on a CGM. Any advice on
Wow.
how I can get him to change his mind?
Wow. Okay, I'm a guy. I would say change change endocrinologists, but um, wow. Actually, if you have the ability to you can get documentation offline for the CGM and the quality of the CGM, why it's a better choice than finger sticks. I would go to the Abbott website and I would pull up some of that technical information and just say, hey, or the Dexcom website, your choice, and just say, hey, this is going to change my quality of life. Again, I'm the patient. Patients ask for products all the time, and even drugs because they're advertised. So you have the ability as a patient to control your destiny, should we say, at this point. So I would 100%, being a type 1 on insulin, even if it's one shot a day, I would highly recommend uh, finding a doctor that will order a CGM. Now, again, we're talking about practitioners who do order. It's internal medicine. It is endocrinologists. It is your family doctors have ordered CGM. So it's not limited to the endocrinology suite. So if you have a family practitioner that's willing to do that, that might be the option for you. So.
All right. Thank you. Once again, if you have questions, please put them in the question and answer section, and I will let Joe go ahead and continue.
All right. Hey, we're going to go next. All right. So ADA recommendation policy, expand the coverage to align with ADA standards of care. Eliminate the burdensome authorization steps. I'm not sure how many nurses are on board that have been dealing with authorizations. They even have authorizations for some of the pharmacy benefits. So, you know, an authorization is, hey, we need the documentation that says this is, this is needed. We need the clinical notes. And for most part, most insurance companies are fairly quick at getting that in. Average is 3 to 4 days, so that's a delay in care for this patient that may need this a little more quickly. The broaden the prescriber eligibility. Well, that's happening. That's, again, I discussed the family practices. There are a lot of physicians and, excuse me, clinics that are prescribing. So, and they're going to invest in patient and provider education. And once again, knowledge is power. Knowledge is, hey, this is a wonderful product. It's a wonderful tool that we as caregivers have in our toolbox. And being able to let our patients know that, hey, this is out here. This is, are you tired of those finger sticks? Do you see, grandma come in and she's got those little black dots all over all of her fingers? I've seen it. Let's change that life for her, and see if we can bring her up to this day and age. So ADA is working hard at changing those standards of care. I know they're working hard to actually pushing a lot of, hey, can't this be handled at the pharmacy so it's a little simpler process for the patient, those kind of things. Again, with the readers being able to transmit that information to the physician's office, they'll know if the patients are using it or if they're non-compliant. So that helps, expand that. Wow, I didn't even look at the spelling convergato align. Oh man, I'm so sorry for that. Coverage alignment with ADA standards of care. Anyhow, I squirreled. Let's go to the next slide, please.
Yeah, and Joe, I just had a
Yeah,
question that came in. And this is somebody who is a type 2. They're on the Libre 3 Plus, and they suffer constant itching from the sensors. Are there any remedies for itching? I know it's rare, or it's
it
very rare
happens.
for their sensor to last that 15 days. And I know you've told me
Yeah.
that you've had a little trick.
Yeah, I had that problem with Dexcom, and I tried everything from Flonase to Coloplast. I've done a lot. I just couldn't get it going. So if you're done with when you're ready to change sensors, okay. So again, shave the area. That works. That helps. The second thing. You're going to take Flonase and you're going to actually literally spray it with Flonase and rub it in, let it dry, do it again. So a couple of doses of Flonase, that's over the counter. All right. So once that's dry, now you're going to wipe it with the skin tack, let that dry. I know it's a process. And then you're placing your sensor. See if that helps. If it doesn't help, it just may be an allergy to the adhesives that they have in there. Um, I had an actual original allergy to the 14-day. I wore it for a long time, and then I started getting it. And then once at that time the Libre 3 came out, and I switched over, and it wasn't there. So um, anyhow, try all of those things. If they don't work, maybe ask your doctor about switching to the Dexcom just to see the G7. It's the little round one. Ask them to see if they can switch you to the G7 and see if it's an adhesion or adhesive issue. So that's my recommendations. It's hard. Allergies, myself, I suffer with those, and I have there are actually Facebook pages for Dexcom allergies. If you look it up, it's horrendous to see the rashes. It's Dexcom rash Facebook page. Yeah. it's out there. And so you get to see that people actually do suffer from this, and they literally are a kind of a talk about group. I don't think they're much of a support group, other than they do have a lot of suggestions on how to help it. But again, shaving, Flonase, skin tack, and see if that helps. And if it doesn't help, then maybe we're going to look at, maybe talk to your doctor about a over-the-counter allergy, like an Allegra or something like that. I don't know. That might be an option as well. So I can only suggest.
And then another question here is, if there's any more information regarding like pharmacy versus like, I would say the medical supply company providing um, the monitors. Is there like a price difference with those? I think it's kind of the question where they're going to. Um, I don't know what the benefits versus the,
Yeah.
you know.
So yeah, for all of the manufacturers, they do have a receiver or monitor, and historically, Dexcom has been the higher priced option, uh, especially like for your patients who either have a fixed income or a copay that they got to worry about. Um, Dexcom by far is a higher price than, say, an Abbott reader. Now, I'm not pushing one product over the other. I'm just saying there is a cost difference between the two. There's also a cost difference between the sensors of Dexcom and the sensors for Abbott. So again, cost effectiveness for most of our patients is a key. And, we can research that. A lot of insurances, again, will cover both. So that's the good news, but it depends on how much your copay will be for those. Now, if you go to a pharmacy, some of the pharmacy benefits are better than the durable medical benefits. So, having your patient check both of those within their insurance company would be important, because they need to call their insurance company and say, hey, is the CGM covered under my medical policy, or is it covered under my pharmacy policy? And that could be a big difference for how much they have to pay for a copay or their deductibles. So, very important question to ask, and it is a concern out there with today's financial environment. So,
Well, and I think also in a lot of situations, um, some insurance companies, especially with like, certain private insurances, they may dictate that you have to go to a durable medical company or
correct.
you can go to your local pharmacy. So I think it's also looking at what the insurance requires a person to do.
Correct. And especially true for Medicare. And, Medicaid is also one that will say, hey, this is a pharmacy versus a medical. So, again, the patients need to know what their insurance can cover in that. And a lot of times they don't. They'll just, I have Medicare, it's covered. Well, yeah, that's true. But, you know, if you have a traditional Medicare, it's covered. Most traditional Medicares are an 80/20 plan, and they would require to have most patients usually have like an AARP or a secondary insurance that picks up that extra 20%. At that point, most of the times it's covered at 100%. But a lot of patients don't understand that when they say they go to AARP Medicare plan. It's a PPO or a HMO plan. It has different coverage options, and they may dictate uh, what kind of product you get. They may dictate, hey, you got to go to pharmacy versus medical. So, again, us as nurses are out there trying to guess what does this patient have. Oh, okay, how do we find that knowledge of what insurances they have? It's taken me 20 plus years in sales to kind of learn all of these things. There is no straight document out there for insurances versus all coverages, because they all change. By the end of this year, we've had insurances change their coverage plans in March. And it's just like they just started a new plan in January. So again, that moving landscape keeps patients guessing, it keeps us guessing, and it's a pain in the keister for all of us. So, but knowing, hey, the resource is going back to the source of the insurance and ask those specific questions. Is a CGM covered? Yes, no. Who covers it? Do I have to go to a DME? Do I have to go to a pharmacy? And so having that in your knowledge base helps focus that patient to where they need to go. All right. Summary and key takeaways. As we know, CGMs transform the diabetes management. It improves accuracy, ease of use, and adoption, and definitely patient outcomes improve with greater access and education. I think the biggest one here, I mean, I love that, it's done all these things, but the patient outcome, and that's what we're here for. We're here to see positive movement on blood sugars. To me, here's how I see the future. We're going to have some kind of implanted device that's going to read our blood glucose, our blood pressure. We're going to be able to, we dream of the day that, Scotty or the doctor scans us with a thing and it just tells us everything happening. So, yeah, that's probably on the way. It scares some of us, but yeah, we'll see. But this is a step in the right direction. Our patient outcomes improving. So, I'm not going to hold up too much of your time. I see we only have a few minutes for questions, but fire away. What questions do you have? Hopefully, I can answer. Um, Jen, did you get that last sheet I added in there? I added a pharmacy review. If you can go down real quick
Yep, let me.
to the resources. Thank you. There's the questions. Da, da, da. Thank you for attending. We got the references. Okay, now go down one more. Okay. So I am not an expert on kidneys, and I will be the first to say that, but I did find this article very interesting. So I tagged it along, and this is for all our kidney practitioners, and that it's really cool. It does talk about CGMs and chronic kidney disease. So please take this, read it, learn from it a little bit. Um, it's a growing environment, and it's very important to all of us as practitioners and nurses. So we can go back to the questions if anybody has any.
Yeah, and I think one of the things that we know for those that do work in the dialysis centers and even transplant centers, patients that have better glucose control, it helps their kidneys. And so, especially
Absolutely.
after transplant, when the person's glucose is better controlled, it helps risk, the loss of that transplanted kidney. And obviously, with patients that are on dialysis, having to deal with, high blood sugars, low blood sugars, having those monitors, I think again is going to help with that compliance. And I think there's also a little bit of a psychological piece of it. Like, for people, if
Yeah.
they're, they eat that bag of potato chips or that, 20 candy bars at Halloween, they're fearful of checking their sugar. But when they have that continuous glucose monitor, it's
It-
telling them in real time what's going on with their sugar. And so there's a little bit more compliance with their diet because of that. And so, um, yeah, at this time, if you have a question, please put in the question and answer. I know we had an attendee that commented that they really liked this presentation and that it was really
it-
informative. So we want to thank you. All right. So at this time, it looks like there are no additional questions. Um, I will, when we send out information about the evaluation. I will have our team also send the slides so you have these references and have this information to be able to go back and look on. So thank you so much for being with us this morning. Hopefully that we'll see you at some of the upcoming events here in the next few months. So thank you, Joe, and we
Thank
will
you.
talk with you all soon.